Welcome everyone. Today we're going to dive into Chapter 6 of Professional Communication in Audiology, which covers a critical, though sometimes overlooked aspect of our daily clinical practice, documenting. We'll be discussing the philosophy behind the medical record, the double-edged sword of electronic medical records, and best practices for recording our specific audiometric data. Let's start with the foundational concept. Back in 1971, Dr. Lawrence Weed gave a grand rounds presentation where he said something profound. Quote, "The medical record is the patient," unquote. Think about it for a moment. As providers, we see dozens of patients a week. We simply cannot retain every symptom, history detail, or treatment plan in our heads. When the patient is not sitting right in front of us, that written record becomes them. It's all the accessible information we have. Furthermore, if you're out sick or the patient moves, the next provider relies entirely on your notes for continuity of care. Because this record will be seen by referring physicians, auditors, and possibly legal teams, it is absolutely must be organized, accurate, and clear. So the key items here are Dr. Lawrence Weed equated medical records to patients themselves. It's impossible for us to retain all that information that we get from the patients. In the absence of the patient, the medical record is the patient, and it represents all the accessible information. It's essential for continuity of care when another provider takes over, and to be effective, records must be organized, accurate, and facilitate clear communication. It's important to distinguish between documenting and reporting. Documenting is the raw data gathering. It's recording the test results and the specific details of the patient encounter. We document to demonstrate our process for reimbursement, to survive Medicare audits, and to have a baseline for future follow-ups. In contrast, reporting, on the other hand, is the synthesis of the data. It's where we summarize and interpret the findings, the assessment and the plan portion. While documenting is about capturing the facts accurately, reporting is about translating those facts into actionable insights for the referring physician or for the patient or whoever the reader is. Today, most of our documentation lives in an electronic medical record, or EMR, or electronic health record, EHR. The EMR is incredibly powerful. It gives us the flexibility to instantly locate a patient's history, view notes from their primary care doctor or ENT, and coordinate care across different specialties. It brings a level of efficiency and continuity that paper charts simply could never match. However, with great power comes great responsibility, and EMRs have introduced new challenges. There we go. EMRs have introduced new challenges, and some of those challenges first are privacy risks. You have access to a patient's entire medical history, but you must avoid digging into areas that are simply none of the audiologist's business. Second, there's replication errors. EMRs make it very easy to copy and paste previous medical history. If a previous provider made a mistake and you blindly replicate it, that error gets perpetuated forever. And then finally, verification need. Never accept an old medical record as absolute truth. A patient's condition changes over time. Always verify their current history directly with them during your encounter. Now that we've covered the why and the where of documenting, let's move into the what. We're going to break down how to document the specific data we collect during a hearing evaluation. When we use an itemized or a checklist approach to our documentation, we ensure we don't miss anything, and we make it easy for readers to find what they need. The core components we must document include the subjective case history, otoscopic examination, admittance results, hearing sensitivity or pure tones, speech audiometry, and otoacoustic emissions if relevant. Let's look at the best practices for a few of these. For your case history, keep it targeted. A referring physician doesn't want to read a novel about symptoms the patient doesn't have. Focus on the relevant characteristics and use visual emphasis like bold text for abnormal findings, so the reader's eye is drawn right to the problem. For otoscopy, describe what you see, don't diagnose. Say presence of occluding cerumen rather than impacted wax causing conductive hearing loss. Highlight anything that requires medical referral or might interfere with your testing. So the key is targeted history, visual emphasis, otoscopic reporting, descriptive language. When documenting admittance, we record the raw numbers: ear canal volume, tympanometric peak pressure, static compliance, tympanogram width. However, to facilitate communication with other providers like ENTs or pediatricians, it's highly recommended to use the Jerger classification system. Calling a tympanogram type B or C instantly communicates a clinical picture, like fluid or eustachian tube dysfunction, to a physician who might not know how to interpret specific decapascals or milliliter values. The audiogram is the centerpiece of our documentation. It's a fascinating look at its history. It was actually developed in the 1930s by hearing scientists Fletcher and Wagle and an otolaryngologist named Sir Prince Edmund Fowler in 1951. Fowler established conventions that we still recognize, like plotting the graph downward and using red for the right ear. He even argued for using blue for the left ear because the word blue contains an L for left. Actually, that wasn't what he originally argued for. He originally argued for using L for lemon or lead, so basically a yellow or a gray color, but accepted blue later on. There were other conventions that he tried to adopt that didn't take off, like using a circle or a circle with a dot in it to represent circle representing the right ear, and then I believe, the dot representing the right ear and the circle representing the left ear, which that never took off. Today we rely on standardized plotting guidelines established by ASHA and ANSI to ensure consistency across the profession, but there's no worldwide standard. We still see differences around the world, and even in some areas there are differences across clinics, like sound field measures, for example. While the traditional graphical format, the audiogram is great for quickly visualizing the degree, configuration, and symmetry of hearing loss, it isn't the only way. Some facilities like the VA medical centers and the military rely heavily on a tabular format where thresholds are simply recorded as numbers in a table. This often integrates much more cleanly into EMR systems and avoids the messy visual overlap of masking symbols. Ultimately, technology shouldn't dictate your care, but you should choose the format that communicates most clearly for your specific clinical environment. So the benefits of the graphical format is it's the most widely used for reporting based on ANSI and ASHA standards, utilizing standardized symbols, circles for the right ear, X's for the left ear, differentiating air and bone conduction, as well as masked and unmasked thresholds visually. Highly useful for simultaneously documenting degree, configuration type, and symmetry of loss. But the tabular format, it integrates better with databases and EMR systems, and it removes the risk of symbol overlap and misinterpretation of complex graphs. For speech audiometry, you must document thresholds, the stimuli used, and the presentation levels. I want to highlight one critical point here: monitored live voice. Using monitored live voice yields highly inconsistent scores. If you were assessing for retrocochlear pathologies or tracking changes over time, you should really use recorded materials. Even though monitored live voice is by far at least as common, if not far more common, than recorded materials. For OAEs, remember they serve as a cross-check. Your documentation should clearly state whether the emissions validate your behavioral measures or point to a middle ear issue. Finally, how do we document when a patient isn't giving us accurate responses, such as functional hearing loss or non-organic hearing loss? The golden rule is your final audiogram for the permanent record should only reflect accurate results. Don't plot fake thresholds just because you got them. It ruins the record for future clinicians. Also, relying on generic terms like reliability, like fair for an adult, is kind of useless. Does that mean they were sleepy, malingering, confused? Instead, specifically describe the behavior. Responses were inconsistent and super threshold. Note, however, that pediatric reliability ratings are useful, and those can come in handy, as it helps the next audiologist tailor their test approach. That brings Chapter 6 to an end on documenting. Our main takeaway is that everything we write down becomes the patient's voice when they aren't in the room. By being clear and utilizing standardized formats and avoiding EMR pitfalls, we ensure the highest quality of and continuity of care.